Welcome to today's MESUD Learning Community Echo, Adolescent Medicine, How SUD Fits. Today we'll be hearing from Dr. Lucy Rosenbaum on eating disorders. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before I begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint proprietorship of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And now I'd like to give a quick introduction to our speaker today. Dr. Lucy Rosenbaum is an internal medicine and pediatric specialist at Maine Health. And of course, she is one of our faculty members. And with that, I'll hand it off to Dr. Rosenbaum. Thank you so much for being here today.
Thank you, Bethany. As Bethany said, I'm Lucy Rosenbaum. I'm one of the adolescent medicine doctors at Maine Health in South Portland, and I will be talking to you today about treating eating disorders in the primary care setting. I have no conflicts of interest to disclose, and I will say that my screen is fully shared with you right now, so I cannot see the chat, so if questions or anything like that, just pipe in. So the outline for today, first we're going to talk about eating disorder models for outpatient care, and then go into specifics about anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder or ARFID, and then we'll have some questions and then a case presentation. So thinking about eating disorders and thinking about like ideal treatment team models, like if we could have everyone we wanted on board, what would our team look like? It really, is so important that treatment for eating disorders, regardless of what type of eating disorder, is multidisciplinary. And the key players you want to have involved are a medical doctor, a registered dietitian, a family therapist, an individual therapist, and a psychiatrist. Again, this is like our ideal model. The medical doctor is there kind of monitoring for stability, making sure the patient remains like medically stable to be treated in the setting that they're currently being treated in. You have a registered dietitian who's helping the family or the patient with meal planning and, seeing what they should be eating and, what their body needs. A family therapist is very important because initially, as you'll see, the treatment for eating disorders in adolescents is almost always based in the family. So initially, that family therapist piece is so important to kind of help guide the family through treatment. Later on, as patients get better nutrition, an individual therapist to work directly with the patient becomes more important. And then because there is such a co-occurrence of other mental health disorders with eating disorders, having a psychiatrist on board is also extremely helpful. So again, for many reasons, this is our ideal, but if we could have everyone we wanted to on the team be involved, this is what it would look like. Realistically, finding eating disorder providers is extremely difficult. In general, it's a very underserved area of medicine. I would say it's not the curriculum included in like medical training and dietitian training and psychology training. It's kind of separate and not everyone has training on it. Patients may be limited based off of their location or what insurance that they have. And then in recent years, we've really seen an increase in diagnosis across the board of all eating disorders. So that kind of shortage of providers that was there is only really gotten worse recently. So I would say, again, while this is our ideal, for very many reasons, our treatment teams do not always look like this. When we talk about the outpatient care setting for eating disorders, there has recently been a push to provide more services in primary care, and that is, for a variety of reasons. Eating disorders in general, they most commonly present in primary care. Primary care doctors are the people who are diagnosing them. These are providers who also have long-standing relationships with the family. They're often trusted by the family. These are really stressful times for families. So, having someone who knows them well can be extremely helpful. And then, as we just discussed, resources are limited. So sometimes families are unable to travel to see a specialist, or maybe can go 1 or 2 times, but it's just really difficult on the family to make that journey as frequently as they need to. And, we know too that, if someone's waiting around to try and see a specialist, the earlier eating disorders are detected and treated, the better the prognosis are. So recently there's been a push to increase tools and training for primary care providers so that they feel more comfortable managing some of the medical aspects of eating disorder care, either until the patient is able to see a specialist or if they need a higher level of care until they can get to that higher level of care, or even, depending on the comfort of the provider, being that medical doctor aspect of the eating disorder team. Again, I think if people are ever unsure or have questions, at least here in the state of Maine, we are always available as a specialty team for an e-consult and always happy to take those questions. But again, what I really want to say is that the behaviors for eating disorders are likely to get worse with time, and we really don't want people waiting long amounts of time to see a specialist. And our hope is that, all providers can kind of guide family in the right direction while they are awaiting further care. So in terms of diagnosis for eating disorders, there are two official screening tools. The SCOFF tool comes from the UK, as you will see, because one of the questions involves the unit of stones, which we do not use. And then there's the eating disorder screen for primary care, which I tend to like better. I include these because we recognize that primary care is extremely busy, and when I see a new patient for eating disorder, I get an hour for that visit, and that's just not feasible. So these are just some easier questions that might help you pick up an eating disorder. And I would say, in addition to these screening tools, growth charts are so important. Really, any kind of discrepancy in growth charts is going to raise my red flags. But as you'll see soon, eating disorders are really defined by behavior now, and not really by as much by changes in weight. So just using growth charts alone is likely to miss a large subset of eating disorder patients. In general, when thinking about a workup for a new diagnosis or a concern for eating disorders, I would say it's really just best to use your clinical judgment. These are some labs that I consider getting in some, if not all, patients. But, I would say overall, there's not a standard. I think if someone is, vomiting, I definitely want to check electrolytes. If, I'm concerned that maybe there might be another etiology of their symptoms, you always want to look into that and rule that out as well. And then in people who have had significant weight loss and who are no longer having regular periods, I do work up that as well, mainly getting urine pregnancy if the patient's sexually active, checking an estradiol level. Less frequently, I do other secondary amenorrhea labs like prolactin or FSH. I would say if I have a really good history of weight loss as a reason why they're not having periods, I do not do those labs. And similarly, in patients who have testicles, sometimes checking a testosterone level depending on where they are in their development can be really helpful and motivating to the patient, because if there is a significant hit to nutrition, that level is going to be much lower than it should be, again, depending on where they are in puberty. Again, thinking about when outpatient care is not appropriate, there are definitely many indications that, a patient would need inpatient hospitalization for an eating disorder. I would say most commonly we use the heart rate, severe bradycardia, or heart rate under 50 beats per minute during the daytime. And then acute food refusal as well, which in this situation, I use 3 days. So if the patient's really refusing to eat anything for 3 days, that's when I say, okay, we need to put them in the hospital. Again, we are always here for questions or to help with guidance if, someone's not sure about this. Looking at anorexia specifically, this is the DSM-5 criteria for anorexia. It's restrictive caloric intake relative to energy requirements that leads to significantly low body weight. an intense fear of gaining weight, and a significantly low weight. It's defined by a weight that is less than minimally normal for children or adolescents. So there's no BMI criteria that anyone has to meet. Really, what I use in adolescents is just deviation from their growth curve is going to help them meet that criteria. And that is a change from prior diagnostic criteria. It also involves an altered perception of one's body weight or shape. And then there are two different types: restricting type, in which, the weight loss is accomplished only by restricting intake. And then there's the binge eating and purging type, where, the above criteria are met, but the patient is also engaged in cycles of binge eating and then purging, either through vomiting or exercise or laxatives. And both of these are fluid categories, so the behaviors have to be happening within the past 3 months. So just because someone starts off restricting type doesn't mean that's where they're going to stay. So it's very important to keep asking, if any binging or purging behaviors are present, even if they aren't there initially, because they are things that we can see develop later on in the course of treatment. Just really emphasizing the change from prior criteria. There's not a specific weight criteria. It is very well recognized that, anorexia nervosa is present in people in larger bodies. Again, it's just that change from their growth trajectory. So if someone is had been tracking in the 95th percentile and now they're tracking in the 75th percentile, that isn't enough of a change where they meet that criteria. And there's also no requirement for amenorrhea to make it more inclusive, because again, we are seeing an increase in diagnosis or more recognized diagnosis in some of our male patients. And I just wanted to stress that, all of these, it's defined by behaviors and not by weight. Family-based treatment, it's going to be the gold standard of care for anorexia nervosa. This is, basically the theory that families are going to take full control of all aspects of their child's eating, with guidance of that multidisciplinary team. So with the dietitian, the therapist, the medical doctor. But this is absolutely the evidence-based treatment and kind of the gold standard of treatment for anorexia nervosa. So it's broken down into 3 phases. Phase 1 is weight restoration. Phase 2 starts when the patient has regained the weight back to their goal weight, and kind of involves gradually transitioning control of meals and eating back to the adolescent. And then phase 3 is really like relapse prevention, and further like more individual therapy, I would say. In terms of phase 1, I really think this is where like primary care providers or initial providers can have the biggest impact, because again, these are the people who are seeing them and potentially making that diagnosis or being their first point of contact. But phase 1, it's the rapid restoration of physical health, which is done by increasing nutrition and getting patients back to their goal weight, and it's all orchestrated by parents. So basically, it takes all decisions about eating and food-related choices out of the patient's hands and puts it in the hands of the parents, and has them fully in charge of menu planning, portioning food, when meals should be happening. Again, we don't want parents like calorie counting or measuring or weighing everything. We have them just follow kind of more general meal guidelines. And we'll be seeing them probably every 1 to 2 weeks during this time. The treatment team's job during this time is really just to coach the parents through everything, so that they feel supported and they have the resources they need. And I think it's common that I'm in a situation, or other providers are in a situation where we've made the diagnosis, but we can't get the family in to see a dietitian or another provider, and we have this kind of lag period. And I find that during that time, it's really helpful if you give parents kind of like easy nutritional goals while they're awaiting that formal input from a dietitian. And I think, okay, yeah. We'll get into what those goals are in the next slide. But just, some things I like to tell family during this time is that really all food is healthy. You really want to be eating, picking whatever the rest of the family is eating or whatever the patient was eating prior to the diagnosis of anorexia, prior to when those symptoms started. You want to reintroduce all of those foods, especially like foods that people may have been avoiding or that they are afraid of. I think it's, a normal reflux of, someone whose loved one was diagnosed with an eating disorder to kind of try to be more permissive and say, okay, like you can just eat more of the foods that you're comfortable with, but we know that that just doesn't work and really prolongs recovery. So really, we don't want people kind of like easing into this. We want them just to kind of hit the ground running. And really, with the malnutrition that's occurred, we're really not expecting the patient to make any good decisions about food. Really, we want it all coming from the parents. So, we don't want parents like offering options or asking patients what they want, because that can often just lead to more stress and will not lead to good decision making. During this phase, there's absolutely going to be like medical side effects from malnutrition and refeeding. Bloating, constipation, worsening mood disturbances are all to be expected. They will all get better when nutrition is better. So that the ultimate treatment for all of that is improved nutrition. And I think people who are very strict in following family-based treatment will not like treat those symptoms or side effects. But I think that's really at the discretion of the provider. This is an extremely stressful time for families. So I think, anything we can do to help kind of make that journey easier, absolutely, is at the discretion of the provider. Some easy methods. So again, you're waiting for a dietitian, the family to formally see a dietitian. Some easier kind of guidance I like to give families. There's the plate by plate approach, which splits everything into a plate and has, you say half of your plate is grains or starches, a fourth is protein, and a fourth is fruits and vegetables. And then you have a portion of fats on the side, either mixed in with one of those other food groups or eating separately. And then you want to have a caloric beverage, and that should make up the content of your 3 meals. In addition to that, you want to be having 2 to 3 snacks a day. You don't want the patient going more than 3 to 4 hours without eating, and you really want to fill the plate. Again, like in terms of what they should be filling the plate with, it should be whatever, the rest of the family is having, whatever would be like considered normal for the family prior to the onset of the eating disorder. I personally think this one's a little easier. It's called the rule of 3s or 4s. And it basically says that patients should be eating 3 meals a day with 3 snacks, and they shouldn't be going more than 3 hours between eating. And then there should be at least 3 to 4 food groups per meal. And I always specify that, I think during this time, I really don't want one of those, if we're going with 3 food groups, to be a vegetable. It should be a protein, a grain, a fat, as well. But I think this is a little easier for families to follow without specific guidance of a dietitian. Again, family-based treatment is very much reliant on caregivers, and if a patient doesn't have a supportive home environment, this really isn't going to work and isn't an option. And that's when we have to work directly with the patient who is suffering from this nutritional brain injury, which, we know that it doesn't work as well when we try to work with the patient and try to put them in charge of everything. But in options where, they just don't have a supportive home environment, that is our only option. I would say in that situation, having like structure and increasing structure around meals can be really helpful. But I have a lower threshold to consider a higher level of care because people need a lot of support in this initial refeeding phase. It's really reframing everything about like how they've been thinking about food and challenging all the disordered thoughts they have, and doing it on your own is extremely difficult. So I have a much lower threshold for recommending like a partial hospitalization program or an online virtual program or even a residential program. And, in older patients who are out of the house, you can use like spouses or, other support caregivers to kind of do a modified family-based treatment model. Moving on to bulimia. So bulimia, it's defined by recurrent episodes of binge eating and then followed by a recurrent inappropriate compensatory behavior. So binge would be defined as eating in a discrete amount of time, an amount of food that's larger than what most people would eat during a meal in a similar time under similar circumstances. That's a really long-winded definition that I think is just trying to say, like, it's not abnormal to eat more in the setting of like a Thanksgiving meal, but it's just in whatever context the patient is in, it would be considered, more than a normal person would eat. And they also have to have a lack of control over their eating during the episode. The compensatory behaviors can include things like vomiting, laxative mixed use diuretics, fasting, or excessive exercise. Any of those are gonna meet the criteria. And the behaviors have to occur at least once a week for 3 months. It has to be motivated by influence of body shape or weight. So, they have to have that element of body dysmorphia, and it can't occur in the setting of another eating disorder. So, if someone is meeting this criteria, but they've also lost a significant amount of weight, that their growth trajectory has changed, that's going to put them in the anorexia binge purge category. In terms of treatment, so cognitive behavioral therapy is really the mainstay of treatment for bulimia. There is some evidence for dialectic behavioral therapy, or a modified version of FBT for bulimia called FBT bulimia. I think like treatment for anorexia, it involves the same like multidisciplinary team, but there's a lot more evidence behind CBT as opposed to FBT for this care. There's also a lot more evidence for medications compared to treatment for anorexia. So we know in patients with anorexia nervosa, that malnourished state, really like SSRIs are not going to work well. That is not the case in bulimia. Fluoxetine is the SSRI that's been studied for treatment for bulimia. It's been shown to be effective. I think other SSRIs have not been studied, but if someone has a bad reaction to fluoxetine or is, done well on a different SSRI, I think it's very reasonable to try like another medication in that same medication in that class. Topamax has also been studied and shown to be effective as well. Really, breaking this cycle of binging and purging and restricting is the main goal. And families, again, play a key part in this. Some easy things to have the families do initially. So if the patient is binging on particular foods, removing those triggers from the house can be helpful. Eating meals as a family can be really helpful. Oftentimes binges are going to happen in secret at night or in bedrooms. So just, making kind of a recommendation or rule of no longer allowing food in bedrooms, having food always be eaten at a table can be helpful. And then you want to monitor people for about 45 minutes to an hour after meals. That we know that's the highest risk time period for purging. So really offering them extra support during this time period. If they have to go to the bathroom, I just say that the door has to be open, or they have to be talking all the time so that they're not purging. I do sometimes, if people are having vomiting and it's not something I think we can stop right away, or they don't have a big support system in place, I do sometimes start Pepcid. There's no evidence behind this that I could find. It just is what was the standard of care where I trained. I think in theory is that it's supposed to provide some esophageal protection and protect some theoretical dentition, but again, this really hasn't been studied, and so I don't know that it actually does have any benefit. Moving on to binge eating. So binge eating is going to be those same episodes of binging that you see in bulimia, but it's just not followed by any purging behavior. The binge episodes have to be associated with, with eating more rapidly than normal, eating until feeling uncomfortably full, or eating large amounts of food when not feeling physically hungry, eating alone because you feel embarrassed, or feeling disgusted with oneself, depressed, or feeling very guilty after eating. And these behaviors are going to have to occur at least once a week over the course of 3 months. Again, in terms of treatment, therapy, and specifically CBT, is going to be first line. There is some evidence for use of DBT, but really CBT is what's been studied the most. Again, some easy behavioral changes. This is going to sound very similar to what we recommend for bulimia, but limiting access to binge trigger foods if specific foods are leading to the binges, not allowing food in the bedroom. And then if someone is having a lot of problems with nighttime eating, I do consider having people lock cabinets overnight, which can sound really intense to families, but sometimes it's very difficult to break that binge cycle, because there's just not that supervision overnight, and patients can find this helpful. So definitely not what I recommend in everyone, but if someone's really struggling, that I do recommend that. Pharmacotherapy. So all pharmacotherapy is going to be second line to therapy, but there have been a few medications that have been studied. I would say SSRIs are what I go to first. A lot of people with binge eating are worried about weight gain with SSRIs, and in this setting, they're not likely to cause weight gain, especially if they help decrease the binging behaviors. Topamax has also been studied, as has Vyvanse or there's been no head-to-head trials that had compared these three medications. Similarly, no other stimulants have been studied. If someone is already on a stimulant, I don't necessarily switch them to Vyvanse, but if I'm starting one, absolutely will do Vyvanse over other stimulants. But avoidant restrictive food intake disorder, or ARFID, I like to think of this as anorexia without any sort of disturbance in body image. But it's a eating or feeding disturbance that results in a patient not being able to meet their nutritional or energy needs, and is associated with either weight loss, a nutritional deficiency, dependence on enteral feeding like Ensures or Boosts, or a marked interference with psychosocial functioning. So any one of those criteria would help meet that diagnosis. There cannot be another medical condition that better explains the symptoms. And then when it does occur in the context of another mental disorder like anxiety or depression, the severity of the eating disturbance exceeds what you would routinely see from weight loss or disinterest in nutrition from depression. It cannot be explained by a lack of food or a culturally sanctioned practice. And again, there's just no evidence of the disturbance in the way in which one's body weight or shape is experienced. So I will say treatment for ARFID is tricky. Again, initial treatment is going to have very similar goals to anorexia nervosa, in that your first focus is going to be on renourishment. But the way that we do that is very different. If you remember when I was talking about anorexia, we say, we do not want to play into food preferences. All foods that they were eating before, really, they should be eating now. We do kind of do the opposite with that in ARFID. We kind of let them eat their safe foods and eat more of their safe foods if they're undernourished, with the goal of just restoring nutrition, and that any calorie is going to be helpful and good for them. Eventually, more over the long term, patients work with dietitians and therapists to, broaden the types of food that they're eating. But that happens over a very long time course. FBT ARFID is family-based treatment that's been modified to fit ARFID. And again, the focus of it is helping parents increase the types and variety of the food consumed by the patient. And really, our initial visits with ARFID is just emphasizing education with the parents of factors unique to ARFID. I also prepare them, if this has been something that has been going on for a long period of time, which it can be, it's something that's going to take a long period of time to get better. And, just to let you know about the resources we have. So we have our adolescent medicine clinic in South Portland. We have 4 adolescent medicine doctors who all specialize in eating disorders. We have a registered dietitian, again, specialized in eating disorders. We are in between behavioral health providers right now, but hopefully we'll be able to find one soon. And then other local resources that are available, there are multiple mental health providers in Maine who work with patients with eating disorders, either virtually or in person. There are Kaleidoscope or CV Wellbeing organizations with dietitians, and then Kaleidoscope has therapists as well, again, specialized in eating disorders. There's our clinic in South Portland, and then there's also a variety of different virtual partial hospitalization programs online. Equip is the one that I'm most familiar with, but again, there's a lot of these programs that offer virtual services. The closest residential program that we have is Walden, and then the Barbara Bush Children's Hospital does do hospitalization for medical stability. And we're happy to assist with that if that's something that someone's worried about.